Hi, everybody. I'm Sam, and today I'm going to be presenting on treating anorexia nervosa. So here we go. All right, so like I said, treating anorexia nervosa, including some pharmacotherapies and alternative treatments. Some topics we're going to cover today include a brief introduction, the diagnostic criteria for anorexia nervosa, the simple assessment model, different pharmacotherapies, the specialist supportive clinical management model, different therapy modalities, responsibilities of clinicians, and different challenges faced by clients. So a brief introduction. Anorexia is faced by about 0.5% of young women in the US and Europe. This is in spite of the fact that it is a chronic and fatal disease with the highest mortality rate of any psychiatric illness, and that is a mortality rate at roughly 5 to 10 times higher of those than compared to those not affected by the disease. And although its etiology remains unclear, it is thought to be composed of genetic and biological dispositions combined with environmental and sociocultural and individual traits. All right, so diagnosing anorexia nervosa, the criteria include, quote, restricting one's intake relative to one's requirements, leading to a significantly low body weight, combined with an intense fear of gaining weight or becoming fat, and a persistent behavior that interferes with gaining weight, even though already at a significantly low body weight. Also, a disturbance in one's weight or shape, and an overemphasis on weight or shape during self-evaluation, and a lack of recognition of already low body weight. And the DSM also has subtypes. It has a binging and purging subtype, as well as specifiers, including a full or partial remission and a severity specifier based on body mass index. And also, just a sort of an aside, the DSM took out the word refusal and replaced it with the word restriction because the authors sort of thought that it was less pejorative. Okay, so a model of integrative care that I kind of threw together includes the simple assessment. And simple stands for standardized inclusive medical and psychiatry evaluation of eating disorders. It's a biopsychosocial assessment model that has 4 areas, and I thought that it was really applicable to eating disorders. It includes individual, family, medical, and environmental factors. Also included in treating eating disorders typically, or not typically, pretty much universally, I would say, is a medical exam and lab work. And that's also pretty much usually recurring with eating disorders. Depending on the client's specific circumstances and needs, a medical exam and lab work is pretty much, it's almost universally done once, and it's often done on a recurring basis during the beginning of treatment. Whether it's done on a weekly or bi-weekly basis depends on how underweight the client is. And this can also include consultation with a specialist, whether it's a psychiatrist, gastroenterologist, neurologist, whatever, depends on the client's needs. Also, pretty much universally included is nutrition counseling, and this will typically include discussion of healthy eating patterns, habits, meal planning, that sort of thing. Treating anorexia nervosa with pharmacotherapy, generally speaking, is not very effective. Treatment with tricyclic antidepressants, SSRIs, even MAOIs has shown to be not very effective when compared with the results of placebos. Also worth considering is the effect or the adverse results of side effects with these medications. With MAOIs, there's the risk of hypotension, tachycardia, and even psychotic symptoms. With SSRIs, there's the risk of bone loss, fracture, and also with atypical antipsychotics, there's adverse side effect risk. In spite of all of this, the use of atypical antipsychotics between 1997 and 2009 doubled, and the use of antidepressants remains stable. So that's curious to me. Okay, so there is a case management model that I thought was really interesting, and also I thought would be particularly useful in treating anorexia. It's called Specialist Supportive Clinical Management. It was created by a woman named Virginia Madsen. I'm sorry, Virginia McIntosh. And she describes it as good quality care delivered by a competent clinician with or without the addition of any specific treatment regimen. And where I think she was going with that is that SSCM, what it's referred as, is really non-directive in nature. And why I think that's important in the treatment of anorexia is going back to the restrictive and kind of control nature of the disorder. And I think that because SSCM is meant to be client directed, I think that letting the client sort of set the tone and tenor of the sessions would be particularly helpful with anorexic clients, because there's such a high degree of fear of losing control. So just to talk briefly about SSCM, it's sort of dichotomous, because on the one hand, it's meant to be client directed, but on the other hand, it's meant to be sort of regimented. It is meant to follow a manual, and it is sort of it's very regimented. So it's a 20-week program. It's meant to meet once weekly, and it's very direct. It's, on the one hand, it is very directed. On the other hand, it's meant to be, the client is meant to set the tone. So it's a both and. But I think that it's very appropriate for case management when it comes to anorexic clients. And if anybody is curious about this, I'm happy to give you more information about it. So a couple or three sort of groups of treatment modalities that I thought would be good, that I thought would be appropriate to discuss when it comes to treating anorexia, are CBT, and then there's the adrenocortical insufficiency model, and then there's complementary and alternative medicine. So first, CBT, which everybody knows about. When it comes to anorexia, CBT posits that maladaptive dietary self-restraint comes from this idea that self-esteem is equivalent to thinness. So the more thin I become, the more self-esteem I'm going to have. When ironically, when it comes to anorexia, generally, the more thin clients become and the deeper into their eating disorder they get, the worse they feel. So it's very ironic. And the purpose or the goal of CBT when it comes to treating anorexia is to kind of untangle that maladaptive thought pattern. And the adrenocortical model posits that sufferers of anorexia nervosa perform their weight-limiting behaviors in an attempt to compensate for this adrenocortical insufficiency. In other words, they have a cortisol imbalance in their body, and they perform these weight-limiting behaviors to correct that imbalance. And some of these behaviors, like excessive exercise and self-harm, actually correct the cortisol imbalance that we have in their bodies. They cause the body to produce more cortisol and increase the metabolic clearance rate in our bodies, and it corrects that insufficiency. And I thought that was really interesting, and it made sense to me. The study that I read, in which they gave clients cortisol supplements, actually showed that it corrected the psychological symptoms and the behavioral symptoms in as little as 2 days or to 2 weeks. And the sample size, unfortunately, was too small to really be definitive, but I thought it was particularly interesting. And thirdly, the complementary and alternative medicine model, for lack of a better term, includes alternative or Zen therapy, hypnosis, electroacupuncture, music therapy, ergotherapy, occupational therapy, the Feldenkrais method, which is awareness through movement, painting and fairy tale therapy, play group therapy, and relaxation, to name a few. And during the 90s, these really grew in popularity. And this also makes sense to me simply for the fact that if we use therapy methods that make sense to clients, they're more likely to stick with them. Okay, so challenges faced by clients. So again, based on the resistance and the high degree of fear of losing control over their bodies themselves and the ability to control the food that they put in their bodies, this is, arguably connected to the high rate of relapse, the high rate of therapy dropout, and the high rate of treatment noncompliance. Secondly, anorexia nervosa sufferers experience a very specific trait profile. They experience anhedonia, low social frustration tolerance, social cognitive difficulties, and the greatest difficulty with close relationships and social leisure. So in other words, people with anorexia nervosa have a common profile of impairments in their social lives, or in their daily lives, excuse me. Lastly, there are very scarcely few resources available for anorexia nervosa sufferers. There are little to no resources for anorexia sufferers outside of, private pay and, private insurance funded institutions. I can speak to what's available, particularly in Southern California. If you do not have private insurance or the ability to pay out of pocket, you essentially are unable to get treatment, sadly. And that is troubling, to say the least. The clinician's responsibility. The clinician must be familiar with the clinical literature, first and foremost, the most up-to-date literature, the DSM, the ICD-10. Men must be able to anticipate future debate as well as any upcoming changes to the literature and therefore to the diagnostic criteria. Doing so makes the clinician able to anticipate, it makes the clinician able to properly diagnose and assess clients. If the clinician isn't aware of the most up-to-date, changes to the literature, the clinician isn't able to assess and diagnose the clients. It's sort of an obvious point, but anyway. If the clinician isn't informed of the most up-to-date changes and debate and the clinician isn't able to be the best advocate for their clients either. If the clinician is aware of the most current standards and information, they aren't able to be the most full-throated advocate for their clients. And lastly, if the clinician isn't or doesn't receive the most well-rounded training and doesn't have the most well-rounded experience, they're not able to be the best advocate for their clients either. When it comes to eating disorders, being trained in modalities like family therapy, CBT, IPT, nutrition, and comorbid disorders, then they're not able to be the best advocate they can be for their eating disorder clients. So that is that sums up my presentation. If anybody's curious about anything that I mentioned, please ask, and I'm happy to share any of the resources that I found. Thank you.